services. Under the Zoom toolbar, you can also find Show Subtitle. And when you select that, you should get subtitling as well. I'm getting some feedback if somebody else is mic'd or if they've got if they're unmuted, please mute, thanks. We've got two groups of great panelists joining us today, and I'd like to introduce them now. First, we have our guest panel representing medical leaders from the State of Alaska Department of Health and Social Services. They are Dr. Ann Zink, Chief Medical for this Alaska, Dr. Joe McLaughlin, Chief of the Section of Epidemiology, Dr. Coleman Cutchins, Staff Pharmacist at DHSS and Testing Lead, Anna Frick, Epidemiology Lead for PPE and Lead for Syndromic Surveillance. Jacqueline Holmes is with us from DHSS as well, as is Dr. Liz Olson, Staff Physician at DHSS and School Lead. We also have ASD leaders and school board members joining us as panelists, including Dr. ASD Superintendent Elisa Vikalis, President of Anchorage School Board, Dr. Margot Bellamy, School Board Vice President, Star Marset, School Board Treasurer, Corey Aist, President of the Anchorage Education Association, Patrick Freeman, President of the Anchorage Principals Association, Sandy Thompson Wallace, President of Totem Association, Dr. Mark Stock, Deputy Superintendent, Dan Barker, the Senior Director of Elementary Education, Dr. Kirsten Johnson, Senior Director of Secondary Education, Dr. Jennifer Knudsen, Senior Director of Teaching and Learning, Tarlisha Wayne, Senior Director of Special Education, Kendra Bartz, Director of Elementary Special Education, Jason Hlasny, Director of Secondary Special Education, Kathy Moffett, Director of Administrative Projects, Jim Anderson, Chief Financial Officer, Andy Ratliff, Senior Director of Budget, Tom Roth, Chief Operating Officer, Jennifer Petronas is the Director of Health Services, Andy Mergens, Director of Student Nutrition, Heather Filt, Senior Director of Transportation, Rob Holland is the Director of Operations, Matt Tieford is our Chief Human Resources Officer, Sonia Hunt is the Senior Director of Equity and Compliance, Andrew Ball is a Specialist in Equity and Compliance, Mike Fleckenstein, Chief Information Officer, Andy Kloop, Senior Director of IT Services, Carol Boatman, the Director of Learning Innovations, and Alan Brown, Director of Communications. At this time, I believe Dr. Bishop and Dr. Zink would like to share a few remarks.
Thank you. As our guest today, I'd love to offer Dr. Zink the floor.
Great. Thank you so much, Dr. Bishop. And more than anything, thank you all for attending and joining. I think that there's nothing more important than the health and well-being of our future. And so I know that all of you are committed to thinking about what that looks like. And COVID has provided many challenges to all of us in so many different ways. And the work is so much less when all of our hands are involved. So I just really appreciate the ongoing partnership and communication. It's critically important to us from DHSS that we're open, we're transparent, we're responsive to the data that comes out. It changes every single day and we get new information and appreciate everyone's partnership as we continue to partner together. At DHSS, we provide information and resources. We do not decide on kind of exactly how schools do things, but we have stood up a school team that includes Dr. Liz Olson, who is a family medicine provider and is here with us today, Barbara Pennington, who is our nurse lead, as well as Deed and Erin Harding. And so the three of them are doing nothing else besides school and COVID these days, trying to make sure that they're supporting schools across the board in whatever they need. We have a team on here, as mentioned previously, and I appreciate, Tim, you introducing them. Anna Frick, as mentioned, as surveillance, but also our PPE experts. We thought we'd bring her along so she could specifically answer those sorts of questions for you. Coleman Cutchins does pharmacy, and so he also does that and testing. So thinking about all the different tests and has been our lead, thinking about HHS testing that's coming out for schools and what sort of resources we have there. And as mentioned, Dr. Joe McLaughlin, head of our EPI team, he'll be joining us slightly late because he's finishing up a vaccine meeting, and then we'll be here shortly afterwards. And then Dr. Liz Olson, who is the heart and center of much of this. If you don't mind, she has a few quick slides that I thought I would turn it over to her to go through a little bit about the CDC and school opening guidelines to be able to share with you all to kind of ground set. Dr. Olson?
Thank you, Dr. Zink. Let me share my screen here. So for this, I wanted to share with you all just a quick note on the new CDC guidance. So the new guidance, many of you are already familiar with this or have seen that ASD has already adapted parts of this for the decision matrix. And so the few things that I wanted to just highlight is that CDC advises using core indicators that have been a part of many of the plans in all Alaska districts since fairly early in the planning stages, including taking into account the case rates in a community, also taking into account how testing is going, and the metric they use here is looking at percent positivity. And then also looking at mitigation strategies. So things like being able to use masks, distancing, hand hygiene, cleaning, and then the ability of the community to do contact tracing. So CDC put out these guidelines last week, and they are already, in many cases, confirming a lot of the things that we were already doing, and also provide sort of a very clear framework for assessing how things are going. I wanted to note one thing because I've gotten a lot of questions about this since these guidelines came out. CDC uses a slightly different way of looking at case rate than the state does. So the state numbers that are on the dashboard report case rates as number of new cases as a daily average per 100,000 over the last 2 weeks. And so this is because we report daily average, it's a number that's 14 times smaller than the CDC's numbers, which are total new cases per 100,000 within the last 14 days. So on the right here is sort of another visual representation of how the Alaska levels, and these are not necessarily the ones that are on ASD site. These are the ones that are on the website that the state of Alaska maintains. So our Alaska alert levels, where we display the case rates, are over here in that leftmost of the two taller columns. And then the CDC thresholds are on the right. So you'll see that CDC uses numbers that look a lot larger, and that's because they're reporting total new cases rather than a daily average. I wanted to mention how things have gone in other districts because ASD is opening later than other districts, and so other districts have already had some experience with opening this fall. So far, we have seen isolated cases in some of the districts that are open. We have seen districts able to implement fairly stringent mitigation measures such as universal masking, such as distancing, such as really making sure that hygiene and cleaning surfaces and good ventilation is a part of planning. At this point, we do not know of any cases of in-school transmission. So while, so from my perspective, that's something that is going well, and I really, really, really hope we can maintain that. The goal is certainly to have no in-school transmission, meaning no one is getting the virus at school. And so I wanted to just mention the Anchorage case rates. So again, the state of Alaska uses cases per 100,000 averaged over the last 14 days. The Anchorage municipality has had 41 daily new cases rolling average over the last 14 days. CDC's numbers are 194, but these numbers mean the exact same thing in terms of new cases. And so I drew a line on the right side of these corresponding charts to just sort of visually show that how these numbers relate to each other. So on the ASD website is the Anchorage municipality number of 41 daily new cases, as well as the CDC metric of about 194 cases. And so I think it's worth considering that even though these are very different numbers, they mean the same thing. They're just different ways of stating that new case number. So in terms of the Anchorage School District, there's the district plan is in place. These core indicators that are adopted from the new CDC guidelines are on the ASD website. And then the 5 primary mitigation efforts are things that are ongoing in ASD as well as other districts in Alaska. I wanted to just make sure everyone is aware of the DHSS role. So the school team, which is includes myself and the state school nurse consultant, as well as a representative from the Department of Education and Early Development. We are available for consultation, and you're welcome to, you or districts or schools or other people with questions regarding school health are welcome to contact us at this email address. Thank you very much.
All right. Thank you. And I wanted to thank our employees and ASD teachers and all staff for the tremendous work. Honestly, last spring when we first moved into learning about COVID-19 and the precautions and safety and working throughout the summer, over 400 people really coming together to assist in setting up schooling this year that has many different avenues and looks to it so that we're meeting our families' needs. So thank you for the tremendous work on that. In speaking to teachers and other staff members, I know that Sandy, your totem folks reach out often in emails, and really the goal is to build the knowledge of all of us in understanding about COVID and about the science side of the COVID and how what our experts in the medical field and others and epidemiologists, what they know to support us and our mission of preparing students for success. It's for us to collectively understand how decisions can be made to safely operate or to not have school. Understanding really about the efforts to understand how there's viral spread and what are the best ways that we can operate to educate children, again, meet our mission and keep our employees and students safe. We do want to focus on the safety as we move forward with education this year due to the needs in our community and the true mission of the work we do. We come to it with love of children and bringing them into a happy, healthy future. And so I thank you for your service to the young people in Anchorage. And the questions that were sent in, as well as we'll have question and answer here, we're just giving a baseline. There's already some questions in regard to when do we get to the questions? I'm just going to ask Jennifer Petronis to piggyback on so that if we can call up our website, just so that our employees and parents and everyone can know, how do we demonstrate and are transparent with that knowledge that Dr. Olson shared the CDC and where it comes from, and we want to show how that would look like on your school district's website. Thanks.
Thank you, Dr. Bishop. So on the ASD public site now, we have both the old 14-day rolling average as well as the new CDC indicators with the current numbers that we are going to update and maintain daily. So from this, the core indicators, the top 3 are the number of new cases per 100,000 within the last 14 days, which is the case rate, the percentage of positive cases in the last 14 days in Anchorage, and then the ability to implement the 5 key mitigation strategies that Dr. Olson mentioned of masking, physically distancing, hand hygiene, respiratory etiquette, cleaning and disinfecting, and contact tracing. And then some of the secondary indicators include the percentage of changes from these 7 days to the previous 7 days, the number of hospital beds available, ICU beds available, along with the number of COVID-19 patients that are currently hospitalized, and the existence of localized community outbreak that's defined by the health department. So all of these numbers we're going to continue to update every day so that the community can get a snapshot of where we are as a community. This, in my opinion, is a little more inclusive of everything that's going on in our community, as opposed to just looking at one specific number and depending on that. Because from this, the secondary indicators, so, what's our capability of hospitalization if it got to that, as well as are we trending up or down? And as you can see, we're trending down, and this number changes daily. And this is on the ASD K-12 public site.
All right. Thank you. And I just turn it back over to the moderator.
Oh, that's me. All right. Well, now we're going to transition. Let me first thank Dr. Zink and Olson for sharing the information that you shared, and thank you to you and your team for being here as panelists today. We certainly appreciate how busy you guys are on a statewide level, and we appreciate you coming and spending time with us, helping us work through some of these things. Thank you too to Dr. Bishop and to Jen Petronis for sharing a little bit more about the district's plans changed recently and why. That's extremely important for us to keep in mind as we move forward. So now we're going to transition to addressing your questions. So questions posed to our panelists today come from questions that many of you submitted when you registered for this session, as well as from the Q&A feature opened at the beginning of this session. And I'm sorry, I should also say, for those of you that were looking for closed captioning, I see it in my toolbar now that I'm not sharing. It actually has a closed caption icon, so feel free to click on that to be able to see the closed captioning. But with over 1,200 participants that had registered for today, we are not going to be able to answer 1,200 questions, but we are going to do our best to address as many of them as we possibly can, and know that we do have 2 more town hall sessions coming up next week, which I'll share a little bit more about toward the end of our session today. So looking to our Q&A, here's what we're going to do. I have a list of questions in front of me on my other monitor, and I will be reading those questions and hopefully trying to direct them where they might go. But I'm going to invite Dr. Bishop or any of our panelists to please step in and help with that direction if it seems to be misdirected, because we want to get the questions answered by those who can answer them. So the first question is, how can we best keep our students safe and their parents feeling confident about their return? Dr. Bishop?
I can certainly answer, but I think our guests and around the safety feature should be paramount in answering these.
Yeah, I'm happy to start. It's a great question, and I think it kind of summarizes probably a lot of the questions that are in there. I think that it's easy, a dichotomous situation, safe versus risky. And the reality is that we all live in a world where there is mitigation of risk, and it isn't just one or the other. So I get questions all the time, if I do this, will I be safe? Versus if I do that, will I be at risk? We know that driving down the highway may cause an accident, and you can be permanently injured or killed from that. And we have ways that we try to mitigate that. We have seats we have, divisions between the highway, we have seat belts, we have airbags, we have industry standards, we don't drive drunk, we use our headlights, we do all these things to mitigate it. But even with that being said, we have accidents, and we try to do our best to minimize it. And I think of it in a very similar way with COVID. And so this is a risk. It's out there. Many people do just fine, but some people get very, very ill, and some people get quite sick, need hospitalization, and some people die. And it's a risk. The enemy's the virus, not each other, and we find ways to mitigate that risk. But that risk mitigation is going to be different for each and each individual family and each individual person. So the risk level for me may be very different than the risk level for Dr. Olson. And we may choose different risk levels in what we do based on who we live with, our own medical conditions, our own personal comfort level. For schools, there is a really good checklist on the CDC website that actually has you go through and you can say, is this risk appropriate for me? Who else am I living with? Who else am I in a close contact with? Who else am I caring for? What are my underlying medical conditions? And is in-person school right for me or not? And so I would encourage people to take a look at that list, because that conversation is very, very individual and is going to be individual for each person. We do our best at the state level to try to mitigate the systems, kind of like creating speed limits on the highway and putting roads together to minimize it. But that doesn't mean that it is not risk-free, and it doesn't mean that we don't have a lot of partnership with individual people to find ways. And then the other thing about feeling safe and confident, for me, that's a two-way conversation. We're able to share our information, express our fears, have conversation about what it looks like, be open-minded, and being able to partner together. And so that's why we have lots of Zooms. I appreciate so many people tuning in now, but always encourage people to tune in to our public echo. We have a healthcare one, we have a vaccine one. We do about 17 different echoes a week to support people and have a two-way conversation. And so from my perspective, it's being able to understand. I think humans can deal with adversity, but it's easier to deal with if you know what it is. So know what the risks are and know how to mitigate them. And therefore you have power and control over this virus rather than letting it have control and power over you.
Great, thanks for that summary. I appreciate that. Next question. Why did we change the guidelines for school reentry? Dr. Bishop?
Sure.
I promise I won't send every question to you.
No.
Today.
I understand. Certainly, it was touched on earlier. What we knew back in March, say, is a lot different than what we knew about the virus in June when we were making plans with the School Start Task Force and the different teams. And we are a learning organization. We're an adaptive organization, and we receive new information. And so as the new updates by the CDC, and I know that, some of the questions that came in were questioning the CDC, but the World Health Organization, as well as the American Academy of Pediatrics, are very in line with understanding the needs of children, as well as how we look at the virus and the viral spread in the community. And so the new guidelines allow us to build the knowledge around how to operate safely and very similar to operate safely as an individual. Dr. Zink shared, you become more knowledgeable. It's a two-way street. You start to build that competency and understanding. And simply as a learning organization in the district, that's what we have done as well. Certainly, if our actions were what they were last March with what we knew, we wouldn't even be in online, schooling the way we are and doing some different things around our community. So it's the growth and the new knowledge, as well as the science behind it, to understand the risk, as well as understand the health and social and emotional needs, as well as the academic needs of young people and the interaction of the virus with them. But back over to those in the science world. I answered the school-based one, but I don't know if there's any additional things.
I think the only additional thing I have to offer, as Dr. Olson mentioned earlier, each district is approaching this differently. What this looks like in Unalaska is very different than what it looks like in Anchorage. And so some school districts are closed with one case in their community because that is a lot of potential spread for that community versus Anchorage. I think it might be a bit before we get to one case, but hopefully get there shorter than later. And so we see a lot of variety, and I think it makes sense in our state. It's very hard to take the modeling and predictions that happen in other states and apply it to our state. When I talk to modelers around the country and I say, how would I take that and apply it to Alaska? They say, don't. They say it's impossible because we have this incredibly geographically diverse state, and the kind of the outbreaks and the ways that we see patterns of disease are very Alaska specific. And so we try to provide very Alaska specific tools and resources to be able to move forward. I think the other thing that's really changing a lot is the role that masks play in transmissions. So when buses, or we look at close indoor spaces, or we look at airplanes, there's a lot of data coming out from early on in this pandemic when people weren't wearing masks, and it's harder to know kind of the role that masks play in mitigating it. But again and again in outbreaks, we see that masks can play a really important role at minimizing the transmission of spread, particularly when people are inside and in classrooms. The degree of that is hard to know, partially depends on how well people are wearing it and what type of mask you have on, so there's a lot of variables. And that's why we brought Anna Frick on here from our PPE team and is happy to kind of talk more about those questions. But I think that data and science is changing rapidly and is making us all kind of feel like we need to change and approach it. And I also think testing is changing. We have a lot more testing than we initially had. And so we're able to see this disease and virus. Initially, it was really clinically based, and we really learned that you can't make a clinical diagnosis off of it. And that's why the CDC has in there the percent positivity. That gives you a sense of how bright the lights are in your community, like how much of this is really seeing, so that you know if you can chart a path forward. Because if you're blind, you don't know which way to go. And so that's why the percent positivity is important, and that's why we put a lot of time, effort, and resources into doing testing. Anna, would you have anything else to add about kind of the recent changes in science and data on masks and ventilation that you've seen resulting in changes in school plans and metrics moving forward?
Yeah, sure. So we have started recommending that people wear masks whenever they're around other people. We didn't recommend that at the start of the pandemic because that wasn't something that we had a lot of data on. Our older research, people had done research on what we might do in the case of an influenza pandemic and what to do about masking that situation. But most of that research had focused on using traditional PPE like we would in a healthcare facility, so surgical mask type stuff. And at the time, they hadn't sort of considered in that research, from 10 years ago, that we might be running low on surgical masks or on N95s. And so we didn't, at the time, it didn't make sense for us to tell everyone to wear a mask when we didn't have enough of those for healthcare providers. But and we also didn't want to recommend that people wear cloth masks when we didn't have data to sort of support that would be a useful thing for people to do. So now we have a lot more research, and we've sort of reconsidered some of that older research as well. And it also does, it supports the idea that cloth face coverings are helpful and that they do provide benefit to protect people who are around a COVID positive person, and also that there's probably some benefit for the wearer as well. And additionally, our PPE supply chain has eased up a lot, so we no longer have those same level of concerns about there not being enough PPE for our healthcare workers. So we do think that masks are a good idea, that they're helpful, and that they do a lot to the spread of COVID in a community. So there's lots of data on sort of the personal and on the societal level to support those ideas. In terms of ventilation, so I'm a little, ventilation is really complicated because how air moves is really complicated as well. I'm sure that some of you guys are science teachers or have talked to science teachers about some of the experiments you can do with sort of how gases move. And we know that a gas will fill the volume of its container, but it doesn't just sort of expand out in straight lines. The particles are bouncing around and they're moving quickly and they're going in all kinds of different directions. And so how air flows through a given room and through like a complicated ventilation system, like in a school with many rooms, is difficult to measure. And so ventilation questions it's good to involve people with expertise in HVAC systems in discussions of ventilation, because they have a much better handle on how air is supposed to move and how different things that you might do could impact how the air moves. But generally, some things that we think are a good idea are, one, to make sure the ventilation system is working like it's supposed to be, that it's working how people think it should be. So that means that there are air filters in place in the places that they're supposed to be air filters, and that those have been cleaned and that they fit snugly. So that's one thing. Another thing is that we think that there's some benefit to having there be more airflow, meaning that we could sort of dilute the volume of air in the room by putting in more outside air or more clean air that's sort of been recycled through the room, but it's gone through a filter. And the idea behind that is that if I'm sitting in a room with several other people and I have COVID, I am breathing out little virus particles in blobs of saliva. And if I have my mask on, most of those particles are never going to get to those other people in that room. But if I'm in there for a long time, some of those particles might eventually make their way to others. And so if there's more airflow moving through the room, that will dilute the some of those virus particles will get washed out and with that new airflow, and then that decreases the chance that those other people in the room will breathe in enough virus particles to get sick. So that's kind of the idea that we're going for with those things.
Well, you just answered the next question. Nice job, Anna. Thank you. So in short, we have learned a lot since the pandemic started, and even since July, with regard to risk factors and transmission, the role of PPE, airflow, all of those things that have also helped us inform our risk when considering coming back to school, so that it's a much more nuanced question, and we have a much more comprehensive tool for looking at that now. So the next question is, how frequently do asymptomatic students spread COVID to staff? Dr. Zink?
Yeah, you'll probably find that we will say this a lot, but we don't know, right? So we don't know how often an asymptomatic person would spread it. That we get estimates from the CDC that maybe anywhere from 40 to 60% of asymptomatic spread happens, or people are asymptomatic. We do see in our data that about 20% of the cases that test positive are asymptomatic. We do have more than that test positive prior to having symptoms. So they're pre-symptomatic, meaning they get tested for travel or for pre-procedure. And so they think they're getting tested asymptomatically, but then 2 days later, they get a fever or a cough or congestion. So we see that fairly regularly in our data. So we don't have a great sense of exactly how many people are asymptomatic, and we don't have a great sense of how many of those spread it to other people in general. There was another interesting paper that came out that showed about 80% of cases were spread by about 20% of people. So if you're familiar with economics, this is the 80-20 rule that we see in other things in the world as well. But we're starting to see that as well in COVID. And is that because they are people who tend to mix more with others, or if they just have really high viral loads and are spreading it? Or if they're really sick and so they're coughing and creating lots of aerosolizing particles at once, is still unknown. But those are all factors that we think about as a whole. There's a bunch of other questions I see in the chat box of like, how do we know about asymptomatic and what's happening there? So what happens is when we get a case that tests positive, we look at anyone who may have been a close contact with them, and we ask them to quarantine for 14 days. So quarantine 14 doesn't mean that you have the disease. It means that you're at high risk for being exposed to the disease. And we need to see if it kind of, as Dr. Olson says, cooks or grows in the oven. During that time, it just takes some time to see if that virus grows and shows up. And during that time, we see if people become symptomatic. And with the kids that have been quarantined after they have been in classroom with other kids who are positive, we've tested them and they've all tested negative. And so that's when we say that we haven't seen spread within the state. That is because that's what we're looking at. A kid was in school when they were positive, or they were in sports when they were positive. And then we look at the kids that they were in close contact with, and if any of them developed symptoms or any of them tested positive. That is different than other states. So there has been in-school transmission in other states. So I just want to be really clear about that. We don't have as many schools in session, and we see varieties of outbreaks across our state. So we see different regions have different amounts of community spread. And we do believe that the more community spread you have, the higher risk there is of transmission. You can't spread this disease if it doesn't exist in your community. And that's part of the reason why the CDCs have kind of, the cases per 100,000. It's a way to estimate how much COVID is spreading in your community. We don't have an understanding if asymptomatic people are more or less likely to spread it, except for, like I said, that kind of sneezing and coughing is thought to be spreading it. And we do know that people's viral load is highest 2 days before they develop symptoms, right when they develop symptoms, and those first couple days after they develop symptoms. So that's why it is so incredibly important that everyone get tested at the beginning of any symptoms. Sometimes I hear, let's not test because then our case numbers will go down and we can have schools. I will tell you that is not a winning strategy. That's the fastest way to have an outbreak and a lot more cases. So we really need people to test at the moment they're symptomatic and to get tested, because we can identify that case, we can do close contacts, we minimize that infectious period where they're exposed to others. We also believe there's a component of how long that exposure is may contribute to how sick someone gets. So we believe a mask not only to others, but helps reduce the viral load for you. And so you're more likely to be asymptomatic or mildly symptomatic if you're wearing a mask with a similar exposure. And so that mask provides protection for you as well as protecting others. And so that role of asymptomatic spread is a little bit more complicated given the mask question.
Great, thank you. This is a related question. What does the latest science say about children and the coronavirus?
Yeah, so great. So I'll maybe start that and have Dr. Olson. She is our great clinical data reviewer who goes through a lot of the clinical updates. In general, kids do much better than adults with COVID. We see more deaths and more hospitalizations from influenza than we do from COVID. However, kids can get sick and kids can die. So I want to be perfectly clear about that. It's not that it's completely benign, but they are much more likely to be asymptomatic or very mildly symptomatic. The people we worry about are those who are not the younger kids, particularly those who are over 18. There's some data that breaks at 15, some at 18. And essentially it looks like a progression. So a 2-year-old is at lower risk than a 5-year-old, who's at lower risk than an 18-year-old, who's at lower risk than a 30-year-old, who's at lower risk than a 60-year-old. And so the more years you accumulate, as well as the more underlying risk factors you have, the higher their risk is moving forward. Dr. Olson, any other details about transmission and kiddos with COVID?
Sure. So I think there's two parts to that. One is the chance that somebody gets really sick, and the other is the chance that somebody gets it and gives it to somebody else. So for the first part, Dr. Zink did a really good job of, characterizing that many children are not very sick if they get COVID. Many children don't show any symptoms at all. For that matter, many adults don't show any symptoms at all, which is part of why we all have to be very vigilant about making sure that we're masking and distancing and doing all the other things we know helps prevent transmission. But for the other part of it, for the ability of kids to get the virus and to give the virus, for a lot of this, we rely on data that primarily comes from one really big study of 65,000 people in South Korea. And in this study, we looked at, the transmission by different age groups. And so one of the things that they saw is that children under age 10, and there's nothing magic about the age 10, but that's where they drew the line in their study. Children under age 10 seem to be a little less likely to get the virus and a little less likely to give it to other people. I don't know why, and I also don't know if that's going to hold up in further studies. So this is not perfect data by any means. But in that big study, it gave us reason to think that it may be that kids under age 10 are a little less likely to get the virus and a little to give it to other people. And so that, that was sort of one part of it. But the other part of it was they also looked at that age group 10 to 20. And they found that if anything, those kids were more likely to get the virus and more likely to give it to other people than adults. So, this leaves us in sort of a tricky position. We don't know for sure that teenagers are more likely to give it to anybody else than adults are. But we don't have a reason to say, teenagers are less likely to get the virus or less likely to give the virus to somebody else than an adult is. So for teenagers, we really, really have to double down on making sure that they're doing everything that we are as adults to prevent spread of the virus. For kids, I don't think that that's a reason to relax for kids under 10, because we certainly know that they still can get the virus and they still can. But that's sort of the context that I'm looking at when I think about transmission.
Thank you. And this is maybe both in a school setting, but perhaps in a home learning pod, or maybe even just in a home setting. What is the minimum distance I can put students from each other in order to minimize possible infection transmission?
Yeah, so it's a great question, and it gets a little bit into that same conversation about risk versus no risk. There is some great videos with blowtorches and other things that show really high risk close up and less risk further apart. And so the higher to someone, the higher the risk you are. So if you cough, if I were to cough right in Liz's face and I'm next to her, that may be all it takes to give her COVID at that moment. And it might not take 15 minutes, and I might be, just within 1 foot, and that might be all that it takes. We do have cases of transmission, not in the state but more kind of worldwide, where we've seen cases of transmission that have happened greater than 6 feet. And that tends to happen when people are in closed spaces, congregate settings, and they're closer to each other. And then, as mentioned previously, the ventilation as well as the length of time that people are in it together. In general, the 6 feet tends to be a point where things start to kind of decrease, and that's based on the fact that we believe that most of the transmission happens by droplets. So while this virus is very small, it usually lives in a droplet. And so when you cough or talk or, just are singing or projecting your voice at all, those droplets tend to fall down to the ground within that 6 feet region. However, we do believe that there's a degree of kind of this short-term or short-range airborne transmission, meaning it can linger a little bit longer than 6 feet, particularly if someone's infected in there for a long period of time. It appears to be significantly more contagious than, say, the influenza virus. However, it's much contagious than things like measles. And so there's kind of a risk benefit. Anna, do you have anything else to add to that with kind of the transmission dynamics and with looking at a lot of the cases that you've looked at for the greater and less than 6 feet?
I don't know if I have anything else to add about that. Historically, we've really looked at in hospital situations, which is sort of where the droplet precautions designation is very meaningful. We have a lot of information. People have done lots of studies where they have like a person, sitting in a bed, and they have like put plates out all around the room, and they have tested to see how far out that person sitting in their bed, coughing can land sort of viable pathogen. And so we have a lot of data sort of about that in that very specific situation. But those kinds of studies are a lot harder to do in other types of environments. So I don't know, I have a lot to add other than the more we talk about it, the more I think we're all learning that the physics of sort of how you exhale and like the size of different droplets and how different sized particles move through different air with different temperature and humidity parameters. Like there are a lot of factors in here that, you really need like a lot of physics knowledge to understand. And we're all still sort of learning how we integrate like our understanding of those factors and also our understanding of microbiology.
Thanks. Dr. Zink, could you share a little bit on the spaces with the masks? You shared some good data, or Dr. Olson did, in regard to the British Medical Journal in regard to the mitigation of in our lives not being able, and they studied space with masks and things like that.
Sure, yeah. So there's the British Medical Journal is a medical journal, and they had an article titled, "Is 6 feet enough?" And in an attempt to take all of these grays and make them into colors, into red, orange, and green. And it basically looked at with mask, without mask, outdoors, indoors, crowded space, not crowded space. And with that, they basically assigned a green, orange, or red environment to it. And so very similar to the kind of the concepts we're talking about, crowded, closed spaces without masks were red, outdoor, far away, few people with masks were green. And there's a variety of that. So happy to share that article. We've shared it on some of our social media posting. We've shared it on some of our nightly news conferences. But I think it does a good job of just kind of being able to go through and think about risk in a little bit more of a nuanced way than just 6 feet, yes, 6 feet, no, because it brings in, just as you mentioned, Dr. Bishop, ventilation as well as masks.
Thanks. Yeah, so it's hard to give an exact answer when there's so many different factors at play in each individual situation. Dr. Zink, what can I do to ensure the safety and health of my school community?
So sorry, you broke up there for just a second.
Let me ask the question again. What can I do to ensure the safety and health of my school community?
Yeah. It's a great question. I mean, it partly depends on what your role is in that school community, right? So I think having a symptom-free school is really important. So if you are sick or not feeling well at all, you stay away. I think that's the biggest thing you can do, and that's the biggest thing we can all do. I don't think that's necessarily been our culture with school and with daycare. I am guilty of charge of having taken my kids to daycare when they're little after a dose of Tylenol. And I'll tell you, after COVID, I'm never doing that again. So I think that it's really important that we stay home when we're sick and that we don't expose other people, flu, COVID, or not. So I think that's the biggest thing that we can do. I think that understanding the role of COVID and the ways that you can mitigate it. So again, I talk about the 3 C's, avoiding congregate places, close contacts and confined spaces, and then doing the 3 W's, wearing a mask, washing your hand, and watching your distance. And I think that we all play a role in that. And some people I know are choosing to not go to meetings or school because they can, and because they've got the option to minimize one more person in that building. Other people don't have that option. And there are a lot of factors that play into this. And so we think as a community, we all do what we can to minimize this and to think about our friends and our teachers and our people. I could go into the office much more often with a mask and the rest of it, but I don't, because I don't have to. And I want to do my part to kind of minimize it. But there are times where we have to be together. I have to go into the emergency department. I cannot do CPR via Zoom. And so sometimes we have to. And so doing all that we can, again, it's a much lighter lift when we all do it together.
Absolutely. Next question, Dr. Zanka, it's another one for you. What's your advice for someone who lives with 2 high-risk individuals?
Yeah, that's a hard one, right? Because I don't know the other dynamics in your house. If you have the ability to stay home, if you don't have the ability to stay home, what other risk factors may be happening in your bubble as a whole? And so thinking about how closely you can kind of keep those high-risk individuals protected or not protected. And so those are all individual factors that individual people have to make. And it also depends on what your kiddos need. I have 2 kids and they have different needs and they have different learning styles and they have different expectations. And so even what might be right for my family may not be right for one kid versus another kid. And so I think you have to kind of balance those different things. Good friend of mine, super close with her grandparent or her parents, it's her kids' grandparents. They spent all summer together in a bubble, but they decided that their kids being back in school was critically important to them. And she's a teacher. So they decided to separate from their bubble from her parents. And that was a choice that they made as a family, but that's a risk benefit. That's a very personal one and everyone has to make on their own.
Absolutely. Next question. We had a teacher with a positive test in my school project. Why did the temperature screen not catch the positive case?
It's a great question. And in general, temperature is not a perfect tool. Unfortunately, there is no perfect tool to be able to say, if there was, trust me, we would be doing everything we can to get it out there. But we know that not everyone gets a fever. We know that a fever can be a later symptom associated with it. When we looked at the F11 data for people coming in from China and other places around the world, the FAA did not find temperature screening a very useful tool for them for identifying cases of COVID. And so when we looked at that FAA data, we made a decision to not add temperature screening to our airport testing for that reason. We didn't think that the risk benefit and the time needed to do it was going to get us much gain. That being said, people who work at a long-term care facility, some are doing temperature checks on a daily or symptom reporting because that's a higher risk situation as a whole. But I think the questioner brings up a great point. You can't rely on any one of these things. And I would emphasize you can't even rely solely on a test. So if someone is symptomatic and their test is negative, that doesn't mean that they don't have COVID. They may have the flu and they could have a false negative. And so that's why it's really important that we have symptom-free schools, we have symptom-free workplaces, and if we're not feeling well, we stay home.
Great, thank you. Next question. What is the district's plan for COVID testing?
I'll take that one.
Jen?
I'll take that one. So our nurse leadership team has been very busy the last several days looking into different companies that offer rapid testing. They're looking at accuracy, how's it going to be done, any equipment involved, as well as cost. And they have it narrowed down to a couple different options that now we're just looking at pricing and the feasibility of getting those into our schools before we start in-person learning. But in the meantime, Anchorage does have lots of resources. They have 17 testing sites available that anybody can go to. Most of those you can just go without a doctor's order or any referral. And the majority of those as well, the testing is free. Some of them do charge if you get a exam, like you need a health exam or you're really sick and you need to see a doctor, you'll get charged for that or your insurance, but the actual test is free. But that is something that I'll have more information as we work through that process.
Great, thank you for that. Next question. What will be done if a student comes to school sick?
I'll take that one as well. So if a student comes, or a staff member actually comes to school sick, then their first step would be to go see the school nurse. And Anchorage is following the CDC and the Alaska Smart Start guidelines, where that student or staff member will be immediately sent home. And then they will be isolated at their house for 10 days from the date they started the symptoms. Or they can get a negative test, be 24 hours fever-free, and their symptoms resolving. Or they can go see a physician, get a doctor's note that says that it's not COVID, be 24 hours fever-free, and their symptoms resolving. All the nurses have these documents that outline when people can come back to school after an illness or after a positive COVID test.
Okay, good. And just a follow-up to that, what would the quarantine procedures be for other students in that child's class, perhaps?
Well, if the student does not test positive, then at that point, we'll do nothing. But if at any point the student tests positive, then we'll go through the contact tracing procedures and make sure that anybody that would be considered a close contact is quarantined for 14 days. And we would refer all those close contacts also for testing.
Okay, good. Thank you.
Tim, if I can add to that very briefly,
Sure.
To add to what Jennifer described, I think the other thing to talk to, if we have a suspected case, whether it's a student or a staff member, that's also going to trigger a response amongst our operations staff. Specifically, we'll want to get into any rooms that may have been exposed to COVID-19 and do a thorough disinfection of those rooms and common areas that we think could have been exposed.
So we take care of the student first, then we take a look at what we need to do for the classmates and the rest of the school, and then any affected area we go in and take care of it. Got it. All right. Next question. We're screening adults and staff before entry. Will students get a screening as well?
So the short answer is no. The CDC doesn't currently recommend universal screening of children. We are going to recommend that all parents monitor their children for signs of illness. And if they have any signs of illness, do not send them to school. We'll begin messaging that really hard over the course of the next few weeks, but we really just want parents to know if your child is sick, do not send them to school.
Good messaging.
Why does the CDC recommend that? Like, just curious. Did you hear me? Not sure. Sorry.
I think I'll let Dr. Zink answer that one.
Yeah, so the question, and we have Dr. Joe McLaughlin, who's joined us right so quickly. So the question was, why does the CDC not recommend universal screening? I can't always tell you why exactly the CDC does or doesn't do whatever it does. I do know that in my counterparts in other countries as well as other states, so for example, I was talking to British Columbia, they did universal screening for all of their kids when they went back to school, because they went back in the spring because they have a really late year. They found really high yield associated with that, and they found that the parents were doing a really good job just kind of monitoring if their kids had symptoms or not. And so the extra time and effort for the staff to be doing active screening was not yielding additional results. I haven't seen any published data on that, so I'm unsure if the CDC worked with that, but that's what I've been hearing from some of my counterparts. And again, why it really takes all of us to partner together to minimize the spread of COVID. Dr. McLaughlin, do you have any insight into that one?
Sure. Thank you, Dr. Zink. Yeah, CDC never did say exactly why they recommended against universal screening. There are certain circumstances, congregate living settings where they definitely do recommend universal screening. And I think the idea is, for example, in nursing homes, you've got a relatively confined cohort and without a lot of mixing in the population. Whereas with schools, everybody's going home, kids are going home, staff are going home, and there's always a possibility of mixing. And so that if you test just prior to school entry, that's going to be good for basically a couple of days. And then, all bets are off after that. So I suspect that's probably something that played into their decision-making process.
And I can just add, if you like, because I've read that guidance about 100 times at this point, I think, there were a couple things that CDC was really, really clear about in that guidance. The first one was that this is a decision that is up to districts to decide, and that they recommended that each district make the right decision for their community. The second one is they discussed both the use of universal symptom screening in schools and the use of educating parents really, really, really well on symptoms. And so CDC ultimately recommends that if schools and districts are able to do a really good job of educating parents and making sure that they know how to screen their child at home. They know how to monitor for fever. They know what other symptoms to look for. They know exactly what to do to have those, to pick up on any signs and get tested right away, that can be a really good choice. They note that symptom screening has the same pitfalls as that temperature screening that Dr. Zink mentioned earlier. When you symptom screen at school, it's just a tiny snapshot. You do, occasionally you catch some things that way, but parents have a much more longitudinal view about what that kid looked like all night. And so really making sure that whether or not we're doing any sort of symptom screening in schools, that parent education there has just been absolutely critical in other districts. And ASD clearly has a plan to go forward with that.
So speaking of ASD's plan to go forward with parent education, is there someone who can speak to that plan?
Sure.
Jen,
Is
Tom.
Jenny Knutson there? Yeah. Thanks.
Yes, I'm here. Thank you. Yeah, we do have a plan. We've been gathering information about what families need, and we have created a family resource website. So we are going to be working on the different aspects of helping, parents work with their kids on wearing masks and screening their kid and looking for those symptoms. And we'll be posting those on our family resource website, as well as probably doing social media blasts on that, so we get lots of frequent the word out to everyone so that we can have that information. So there's a plan right now, and we're starting to put those training videos together. Some of them have been created, and we're going to create additional ones as well.
Great. Thank you, Jenny. So the next question is maybe kind of related to, the questioner asks, I would like clarification about staying home if we have cold symptoms. I catch a cold every winter. Do I stay home for 10 days?
I'll take this one. So ASD's theme is going to be ASD is symptom free. So yes, if you have any symptoms, we're really recommending that you stay home for 10 days from the start of your symptoms, or you go get a negative test result. Make sure you're 24 hours fever free and your symptoms are resolving, or you go and see a physician, get a letter that says it's not COVID, be 24 hours fever free and with resolving symptoms, and you can return. So the short answer is yes, unless you get a test or see a doctor.
Okay, very good. What does the communication to the public or parent look like when a student is sent home with a symptom or a positive test?
I'll take this one as well. The nurse leadership team has been just wonderful throughout this whole experience, and they on template letters, both for email and paper, and as well as templates that people can follow if they talk to parents on the phone. So if a child is suspected of having COVID, then the school nurse will call the parent and talk to the individual and recommend, or have them come pick them up and recommend testing, and then have them stay home, as well as sending a letter home. At any point that individual tests positive, then we'll start that contact tracing process. And then we have a different letter that we'll be sending home of those children that we identify as close contacts, that tells them everything they need to do, from what to do while you're quarantining, when to get tested, and when your quarantine period is up.
Okay, very good. Thank you. Can masks be removed in the building if more than 6 feet can be maintained? 6 feet of distance can be maintained?
ASD's policy is that masks need to be worn unless the individual is eating or drinking, and then the mask needs to go back on as soon as that process is done. So no, even if you can maintain more than 6 feet, unless you're in an office alone with your door shut, then you need to be wearing a mask at all times.
To be clear, my office door is shut.
Yes.
To let everybody know.
Do you want to add to that, Dr. Zink?
Sure, I'm happy to add to that. I kind of think of that as like taking off your seatbelt going down the highway. So in general, we want to keep the seatbelt on. And so it may not result in immediate transmission. And so I also think we need to just approach all these things with kindness and humility. particularly when I think of little kiddos. They're going to do things. We need to not panic that suddenly COVID will be there, but we want to just encourage and get it back on as quickly as possible, and using that tool like we use all of these other tools to minimize the spread.
Absolutely. All right, next question. If my school gets quarantined because of COVID, will my teacher or spouse be required to quarantine my kids? What about my kids at 2 other schools?
So that would be considered a contact of a contact. So your spouse would not need to quarantine unless the individual tests positive. So in this situation, it sounds like the teacher was exposed to someone and is quarantining. So the teacher would be recommended to get testing. And if at any point she tests positive, then her family members would need to quarantine as well, because they would be defined as close contacts. But in general, contacts of contacts just need to be monitoring for symptoms, but they do not need to be on quarantine.
Great. Thanks for clarifying that. Sorry, go ahead, Dr. Zink.
Yeah, that if you're quarantining, that also means quarantining from your family if you're going that direction as well. So that doesn't mean lots of loves and kisses for your kiddos and sleeping in the same bedroom as your spouse. Those are all good ways to transmit the disease very quickly. And so they need to truly quarantine for their family. Otherwise, their family then is at higher risk. And what we see is then contact, if they turn positive, then that entire family is then exposed. And we have had families who it's been 4, 5, 6 weeks where that family is essentially all quarantined, because it kind of goes from one person to the next to the next. So the quickest way to get over this is to test early and quarantine quickly.
Right. I wonder what things would look like if we did that with the flu as well, right? We see flus go through families, in sequence like that as well. So, okay. What are commonly experienced COVID symptoms for children 12 and under? I've read that that they're less likely to experience fevers, but more likely to have digestive problems.
Yeah, maybe Dr. Olson, this is one I know you just reviewed the literature on.
Sure. So when I reviewed the literature on children with mild COVID, the first thing that I noticed is there just wasn't very much of it. So I want to be clear that most of the studies that have been published in children so far have been of children who required hospitalization. So that very, very small group of children who got quite sick. So having said that, what we do know about kids is that it's slightly more likely that they report things like abdominal pain, so pain in their belly, diarrhea, vomiting. There's also been reports of a rash. A rash is not one of the CDC symptoms right now, and it's a particular kind of rash. It's not sort of it's the kind of rash where it's something that would be good to show your doctor. So if your kid has a new rash, that's a good reason to talk to a doctor about it. But that's not necessarily one of the COVID symptoms. We don't have a good handle on how frequent that actually is, because those from one-off case reports. So somebody saw something and then wrote a paper about that one case, rather than looking at a population and saying, well, in this population, this many people had this thing. So while kids are a little less likely, as you said, symptoms overall, a little less likely to have a fever overall, we think, a little less likely to have some of the other symptoms, we think. Generally, what I would do is I would take a look at the COVID symptom list that the CDC has, which is the same one that I believe ASD uses. And if a kid has one or more symptoms on that list, I would go ahead and get them tested for COVID.
This is Joe McLaughlin. I can just add, there is a web page on CDC's website on COVID in children and teens, and it provides symptom lists for different age groups. But as Dr. Olson was saying, it's very common for kids to have either no symptoms or very mild symptoms. They do go on to say that kids who do have symptoms, the two most common symptoms are fever and cough. So those are the ones that appear most commonly, but then they add to that chills, nasal congestion or runny nose, new loss of taste or smell, sore throat, soreness, shortness of breath or difficulty breathing, diarrhea, nausea or vomiting, stomach ache, tiredness, headache, muscle or body aches, and poor appetite. So I don't know if there's a chat box. I'm just looking, but I can go ahead and provide that link if there is one.
I don't think we have a chat enabled for this session, but if you can share that link with, well, I'm sure we have ways you can get it. We can maybe share it with the posting of this on YouTube. So thank you for that, Dr. McLaughlin. Appreciate that. So the next question is, I think this is for someone in our district. What are you doing in schools to keep kids and staff safe? Actually, I should say it's a question for somebody in our district, but we could also hear perspective statewide, what other districts might be doing as well.
Thanks, Tim. I'll start on this one, if I might. I appreciate the opportunity to provide some information. So with regards to what are we doing in the buildings, I'd like to kind of approach this. There are really two main lines of effort when we talk about safety in the buildings. The first are the structures themselves, and the second is people, our staff and our students. So I'll start with the buildings. So we over the summer worked through some plans and preparation to help make buildings safer. So the first is we've developed signage for starters, and within these signs you've got two different types. You got warning signs, and many of you have seen in the front of the school buildings, do not enter this building if you exhibit any of these symptoms, and it lists out the COVID symptoms. The other signs are reminders. So many schools you'll see maintain 6 feet separation or wash your hands frequently, and these are reminders. We have one that's in the works now with communications, going back to the theme of let's keep ASD symptom free. We're in the process of preparing posters to remind people not to come into buildings if they're symptomatic. We have introduced disinfection capacity that wasn't there before, and we're continuing to do that with both equipment and with the disinfectant. And I'll ask Rob Holland here in a moment, our director of operations, to go in a little bit of detail about that. We brought in plexiglass partitions. You'll see in all the office areas that we've got barriers in those common areas. We brought in hand sanitizer dispensers. We've increased that kind of equipment in all of our schools. So with regards to people, and there's been a lot of discussion here. So we've talked a lot about the protective equipment. It's both the equipment, the desktop type equipment, but also the personal protective equipment, the face coverings, the shields, the humanity shields. And the district has acquired a significant quantity of disposable masks, both adult and pediatric, a very large number of cloth masks, which are being distributed, thanks in no small part to the HHS for providing a very significant number. Gloves, nitrile in all sizes, from extra small, medium, large, and extra large going out. And then lastly, the topic of training for our staff, our students, and our families that Jenny Knudsen briefly addressed. And then within this, the materials, I just want to assure folks that it's not just an immediate amount, that we have a pretty significant supply of these items, that we are prepared to continue to resource our schools, and we are not intending to run out. So what I'd like to do is I'm going to ask Rob Holland, who, again, our Director of Operations, just to very briefly talk about this disinfectant, because I know there have been a lot of questions about what it is, how it works, and how it's going to be resourced in our classroom. So Rob?
Thank you, Tom. Yes, so the disinfectant that we have is called hypochlorous acid, commonly known as electrolyzed water. And that is literally the combination of water, vinegar, salt, and a process of electrolysis. That disinfectant is something that we can and are putting in the hands of classroom teachers, front office staff. In other words, everyone else in the building that we've never needed to provide disinfectant to in the past. And so that gives us the ability to greatly spread out the mitigation effort to keep environmental surfaces disinfected. We have had a tough time with the supply chain, So we've come up with a solution to cut out the supply chain, and we're simply generating the hypochlorous acid ourselves. And now we have an unbroken supply chain in a sufficient quantity for all of our schools.
Thanks, Rob. Yeah, no, I think so. And just to very briefly talk the way this will be distributed to schools, it's going to be provided to schools in 5-gallon containers. It'll be diluted by BPOs. And then the BPOs will be filling the spray bottles that are inside of classrooms. So that's a very brief synopsis of some of the measures the district has taken to improve safety in our buildings. I'm happy to open to the state representatives if there are other things for them to add.
I think that there's a lot of great things that you guys are covering in there. I think that, we talk about surfaces and hand washing and ventilation that's on there. Anna, do you have anything else that you would add from your perspective, or Dr. Olson from looking at other schools?
I don't think so right now, but if you guys have specific questions, I'm, more than happy to talk through the details of particular things. I think it's really hard to talk about, district-wide things when a lot of these sort of how we negotiate them in the facility. And so, and I know Dr. Olson has talked a lot with ASD about what they're going to come up with.
Yeah, and I would just add too the question was about general safety, but we can do multiple precautions. It is going to be the human element and how we take care of each other. And so masks, doing the very best we can individually. And I know the question in our schools is how will kids do it? And I know every year we do an amazing job of receiving kids from multiple different places, and they're at different levels of their education and understanding. Anything from putting on their own shoes and boots and zipping up their coats to understanding, lunchroom procedures, and some will know how to use a napkin and some won't. And we have amazing educators and people that really receive children. We take them where they are, and then we set that expectation. And in my mind, when the expectation's set and the supports are there, children respond to us. And they are amazing. And so ensuring that we support teachers and the training and supports and things that they need to help their kids, as well as additional help if we have students that find themselves a little bit more challenging, which we know we do. But I think it's my belief in just watching children grow that the behaviors that we expect, we will be teaching them and ensuring that. And right now, there has been interest in sharing from staff that they are not happy with other staff who aren't taking it seriously, or they took off their mask or just something. And we investigate all the time with this. We'll go and we'll address it. So we're not leaving it unaddressed, but we all know that the presence of each other is certainly, and that expectation and that respect of each other should serve us well during this with the collegiality in our staffs and just the expectations. We have it all the time in respecting the classroom next door to us, whether it's, with, timeliness of kids leaving or noise or whatever. This is just another aspect of learning that we're going to rely on each other as a teaching family so that we can take care of each other, because we know if we can take care of each other, we are really, really, really do well at taking care of children.
Okay, thank you very much. The next question is one that I think is similar to one that was asked earlier, but I think it bears repeating. What's your response when you get a confirmed case in a school? Jen Petronis?
I'll take that, and then I think Tom can add to it. If we get a confirmed case in the school, we have a COVID incident report that we began piloting and using a few weeks ago when sports began. And essentially, once the person who finds out about that confirmed case has the information, they'll complete the incident report, and it generates an email out to myself, our emergency manager, Ashley Lawley, and a few others in the district. We'll get more information from the person who entered the report, get all the dates of the when did that person begin symptoms? If they had symptoms, when did they test positive? What have they been doing? Were they playing a sport or were they just in class? All of that information. And then we'll have a quick team meeting where we'll discuss the events and what the options are. The options could be anything from just making sure that student remains on his isolation, quarantining one or more individuals that came in close contact with that person. It could be like a whole team. It could be a part of a team. It could be just a coach, depending on the specific scenario. And then once we figure out who all was a close contact to that confirmed positive, we will start making phone calls and generate an email that will explain everything that we talked about earlier. How you quarantine, when your quarantine is up, what you do if you start getting symptoms, and when your window is to get tested.
Great. And so maybe it's a similar process then too, if there's a student who's riding the bus who tests COVID positive, if that student who tests COVID positive also rode the bus to school, we may include the fellow bus riders in the contact tracing.
Yeah, that's part of the investigation, Tim. That would be one of the first questions asked. Also, whether or not the student had siblings who would be in other schools. I mean, there are a lot of different roads, and it's all situation dependent on what the outcome is going to be. And I just would add, we also are working very closely. Jennifer talked about the contact tracing, and we have a system that's internal to the district, but we're also in collaboration with the health department in terms of what would be a more expanded, if we do have a larger indication of greater spread, that we are very much tied to the health department, and they would probably take a lot of the lead on what would be case management, and as well as a much more potentially expanded contact tracing mission.
Tim, I don't know if there's any questions, but sports was brought up. Kirsten Johnson's here, and we actually have had sports cases and have sports. Would you mind, Kirsten, just sharing a bit?
Sure. We've had a couple of different scenarios, and actually Dr. Zink was kind enough to meet with me earlier this summer as we were starting to start thinking about sports and athletics. And so we've gone through a whole lot of planning around sports and activities to not only prevent through mitigation secondary transmission, which I'm happy to say at this point in time, we have no secondary transmission through our sports and activities, which is great news. But we have had individual instances where either an athlete or an athlete's family member, as an example, have exposed that student to COVID-19. In those individualized situations, we are quarantining those students. We're notifying families and coaches associated with that team that there may have been an exposure. And then we just are very vigilant about monitoring for symptoms amongst that team. There have been more recent situations where an athlete was aware that they were positive, chose to come and participate, and then exposed additional teams that they played against. And in that particular situation, we have quarantined whole teams and teams from various schools that came in contact with that particular individual. So in most cases, it is an individualized situation where we have one or two athletes, but we have not only mitigation plans to help prevent the secondary transmission, but then we also have the response plan, much like we would for in school when we are looking to come back. And so far, we've had really great success with preventing that secondary transmission through our sports and activities. So that's where we're at our athletics at this time.
Thank you.
Great. Thanks for that clarification, Kirsten. So kind of sticking with the busing, there's a question about how busing is going to work. How are we going to get students to school that would normally ride the bus?
Okay, that's a great question. I'll take that. I'm going to ask Heather Philp, who is the Senior Director of Student Transportation, to also come up on this question. So in short, Busing will happen very similar to how it has in the past once we get back into school. So most folks know we have a 3-tiered system whereby the district transports high school, then middle, then elementary age students. We do this with our partner in transportation, Reliant. So what we're really talking about here, what are the changes that are going to happen both at the bus stop and how students will both enter and travel in buses and exit those buses once they arrive at school. So the plan is, and I'll focus on elementary students because they'll be the first. So we're going to transport all students. We're going to travel 2 students per bench. And if you can kind of envision starting this at a bus stop, our intent is to assign seats to students. So we're going to, as best we can, at least start. We expect it'll be a little bit bumpy at first, but to line kids up so by when they enter the bus, it's going to be the kid who has the back seat, back left corner, that kid's going to be the first on the bus, and they sequence on one at a time. If a student doesn't have a mask, this has been a question, but the bus driver will have disposable masks present to issue to students that don't have one. We're thinking that many kids will have them. But if they don't, they'll just be given a mask as they come on and directed to put it on. So 2 per bench, loading from the back, and then when they get to school, they'll unload, reverse order again, front, exiting the bus first, and then they'll be received by staff. Heather, is there anything I missed on this, details you'd like to add?
Just that we'll be offering the hand sanitizer to the students when they get on the bus.
Perfect.
Drivers will be issuing reminders on and off the bus, just reminding kids to keep their distance at their bus stops and as well keep their distance getting on and off the bus. They are going to be exiting the bus in what we call evacuation style. So it's going to be designed and handled by the driver, so there's no rushing on and off the bus at that point. And we are already set up with driver kits for sanitizing, masks, and hand sanitizer.
And Heather, can you talk to the disinfection plan?
Now, each driver will be given a spray bottle for disinfecting in between each run of the bus. So when we release students from the first run and before we go into a second run of picking up students, we'll be sanitizing. They'll spray the bus down, they'll drive close to the first stop, and then they will go back and make sure everything's wiped down. That'll give the process of drying off before we get to the stop after each run. And then in the evening time, our shop here will be using the electrostatic sprayers that we've purchased, and they will be spraying each bus down each night.
Thanks, Heather.
Mm-hmm.
So, Tim, does that answer that question?
Yep, that did. Thank you. Let's see here. What happens when multiple students and staff test positive for COVID? Multiple students and staff. So we know what it looks like when we have one go out. What do we do if we have more than?
So I'll attack this one first. So the district does have a response matrix, and I'm going to, if I might, just share my screen and I'll talk through this particular scenario. So we talked about the single confirmed case. So what if we have multiple cases, and there are a couple of scenarios. So the first multiple case would be inside of a single school building, where we would really think that if that's happening, that we are having transmission inside of a school. So in that scenario, you can kind of see in that middle column, one case on the right chart. So one case in a school, 1 to 3 day time period. So a fairly compressed time period that we truly believe that transmission is likely occurring. We'd go through that process that Jennifer described, where the assessment team would gather information, and as they built that, they would, in this example, probably form a more robust response team to develop options. So those options, given this scenario, would be to close the building for a period of time until we could confirm who was exposed to the virus, and then allow for time for a team to come in and disinfect. We think the time, there's no magic to 24 to 72 hours, other than to make sure that we have identified anybody who has been exposed, put those individuals into quarantine, and then ensure that the disinfection, a very thorough disinfection occurs. And then in all these, we would be notifying parents and any stakeholders that would be involved. So that's a single school, multiple cases. Now, what you described, if we have multiple cases that are occurring, again, in a fairly short time frame, but it's happening throughout the district, this is where the investigation really kind of gets interesting, because you're trying to establish, is there a connection? So say all these things are happening inside of a geographic area. Maybe it's southern Anchorage, multiple schools that are showing cases. So if it appears that it is something that is transmission occurring inside of schools and it's geographic, that we could, again, based on our analysis of options, make a recommendation that we would close a number of schools until such time that we were able to mitigate the risk, put in quarantine individuals who've been exposed or confirmed, disinfect, notify people, and then return to school once it's determined safe to do so. Now, if it's a multiple case and there's no connection, say you have a case in Chugiak, one in South, and one in Girdwood, where there's no connection, then they would all be treated as separate cases, similar to the single confirmed case in the school. So that's kind of the response process and the options that we would be considering in this multi-infection scenario.
Thanks.
Great. Thank you, Tom, for sharing that. So the next question is, how are students expected to properly distance 6 feet with full classrooms and buses? So Dr. Zink, I don't know if you have any guidance, again, looking at what things might be happening elsewhere in our state and what might be working that can help guide us as we move forward.
Yeah, it's easy from kind of a health standpoint to say, stay 6 feet away and wear your mask and wash your hands. It's a whole other thing when you have to put that into practice with a bunch of second graders in a classroom together. There's some just basic math and physics that is sometimes impossible to overcome. The governor always liked to bring that up. 100 people in a telephone booth is very different than 100 people picking blueberries in Denali National Park. And so those risks are different depending on how well you spread them out. We see different school districts doing all sorts of different things to creatively do that. The middle school I was talking to the other day, has green dots throughout the entire school where they spread everyone out on lunch and they all go to all their very random different spots and use kind of all these nudge theories to break them apart and to spread them apart. But Dr. Olson, you look at all the school plans. What are you seeing as some creative ways that people are making sure they're keeping as much distance as they can and minimizing the risk?
Right. And Dr. Zink, as you said earlier, while there isn't anything magical about 6 feet, that risk does decrease with with increasing space in between people. I've really seen things all over the map. Some schools are able to really increase the distance between students. Some schools have created classrooms. There are a variety of different schedules that schools have used. Some schools have instituted barriers, and then there's many other strategies. So I think there's a number of ways to approach increasing distancing. And then, of course, part of what we're talking about with distance is also making sure that ventilation is a part of the plan as well.
And I would just also comment, we do have a school echo for school teachers, and that's a chance for people to share different ideas and hear from each other. And so those happen every week. We also have the science echo, which is one's open for the public, and that's on Wednesdays. And we have a healthcare one where we go through all the literature. And so it's really fun. We learn things from those all the time. And we also have a large gatherings one that happens every other week. And there's some of the characteristics that are very a bunch of sports plans and looking in sports. So if people want to come share ideas and hear other ideas, trying to figure out your own individual classroom, we always invite you to come to that, share your concerns and stories, and learn from other teachers and share what you've figured out's working for you.
Wonderful. Thank you. And maybe we can get, in fact, I know we have somebody who is involved in that project, the ECHO project, that might be able to share that information with our district staff again, too. So looking at the time, it's just after 5 o'clock. I know that we've got over 200 questions in the Q&A. I wonder, Dr. Zink, if any members of your team might be looking through those Q&A questions and see anything that really calls out to you as like, oh, that's the $1 million question right there. If there are any that you feel like I've got a whole list of other questions here we can keep going with, but if there are any in particular that you feel like ought to be asked and addressed in our meeting today, appreciate that.
Yeah, no, I appreciate that. I try to do lightning rounds, but I will tell you 200 is more than I can do for a lightning rounds episode on this. But it always pains me not to answer every single question. And so, we're always happy to come back and try again. So maybe my team is also kind of looking at these. They could each pick a question or a topic that they feel like needs to be addressed. I think the one that struck out the most to me that I just want to be really, really clear about is quarantine versus isolation. And so isolation is for illness, and that's if someone has COVID and they need to be away for a minimum of 10 days. So their symptoms need to be resolving. They need to have no fever for at least 24 hours with no symptom-reducing or fever-reducing medication. And it has to be 10 days either from the onset of their test or onset of symptoms, whatever is earliest. And the reason that's shorter than the quarantine period is because they already got a chance to grow that virus in their system for a bit before it was picked up. So a quarantine period is longer. A quarantine period is for that 14-day period, and there's no test-based strategy to shorten your quarantine period. So the test can be useful in that case that we described earlier with a husband and wife and staff to be able to identify if someone is there to then figure out who else needs to be quarantined. And so sometimes people get tested multiple times in their quarantine, but you just got to let those cookies bake. You just got to let that virus bake and see if we pick it up during that 14-day period. And so I think that's the biggest thing where I see a lot of misinformation. I see doctors' notes giving people permission to shorten the quarantine, and that is not good science. That's not good evidence. We've been sending that information out to providers. We are meeting with healthcare providers to make sure that they have this information. We have made a clearance back to school checklist for healthcare providers so that they are all on the same page as well. But we're trying to make sure that everyone is having a uniform conversation. So I see a lot of kind of questions about quarantine and isolation, and I think that was the biggest thing I wanted to take away. Dr. Olson.
Can I just?
No, sorry. Please go ahead.
I just wanted to clarify, just to make sure that everybody's on the same. That no doctor's note can clear you from quarantine, but how about if you're sick and you're doing your 10 days isolation and you go see a doctor?
Yeah, so great question. So the doctor's note is pretty clear, and you can download it on the DEED website or DHSS website so everyone can see it. Want to be totally transparent. You can bring it to the doctor's office with you. And we don't want healthcare providers to just say, oh, this is likely a viral illness, probably not COVID, because COVID can look like so many other things. But if they have not new symptoms, so say someone has asthma and they always get asthma when they run, when it's cold out, and they start to get short of breath consistent with their asthma, and their primary care doctor knows them and knows that these are not new symptoms, that is consistent with a chronic medical condition, that can count as the doctor's note for that. But if they have new onset of symptoms, we're asking for people to get that COVID test. And we really appreciate everyone standing in this space because this is a lot of new information for healthcare providers. It's a lot of new information for school nurses, parents, for teachers. But we do see in other diseases where school can be a form of mitigation. The more that we do this together, the better off we all are. And remember that COVID can spread in school, but it can also spread outside of school. So when I hear about slumber parties, all eating out of a trough, all sharing food together, that's a high-risk event. And so the more we can do to minimize high-risk events both in and out of school, the more we're going to be able to keep COVID under control and keep kids moving forward with education and keep your classroom healthy and safe. So making sure that we're talking about COVID regardless of where it's at and mitigating that risk in and out of school as a whole. Does that answer your question, Jennifer? Okay.
All right. Anyone else on Dr. Zink's team? Is there anything else that's jumping out at you from the Q&A?
Sure. So, go ahead, Liz. So I guess also, if you guys want us to, I think we could maybe answer some of these questions by typing them in. Just if that's a desirable thing. There are a lot of questions about logistics, so I think that's really up to ASD maybe to answer some of those. But I do see a couple questions about sort of face shields and how do face shields fit into our masking situation. So I forgot we don't have a chat, so I can't post this to you, but there is a page on CDC's website that sort of talks about what they think you should do vis-a-vis face shields. And I guess to summarize it briefly, CDC doesn't think you should use a face shield as a substitute for a mask. But we know that masks create a lot of problems, particularly for people who have limited hearing or for people who have a really strong need to see faces for, other reasons. And so they do provide sort of some additional considerations for people who are going to choose to wear a face shield instead. And so they say the evidence is limited, but they do think that face shields that are hooded or face shields that wrap around the side of the wearer's face and extend below the chin do provide more source control than other face shields. So I guess that's sort of what I have to say about that, is that we think that that an actual face mask is probably better, but the available data says that those face shields that wrap around the face, like the humanity shields I think you guys have been talking about using, probably do something, and those are preferred over a regular face shield that might just sort of go like this.
Good clarification. Liz, did you have something you wanted to add?
I did. The quarantine and isolation thing is very, very tricky. I think it takes all of us 10 or 20 times thinking through that to make sure that we're kind of all on the same page. There are a few resources, including some neat little graphics on the DEED website to get a handle on those. But just generally, I think of isolation as when someone has an illness and when we're asking a question. So when somebody's in quarantine, we're asking the question, do you have that virus? Are you going to develop it? And so we keep you away from other folks for 14 days. We test you during that period of time to find out if you have it and you just haven't had any symptoms. We ask you to watch very carefully during that 14 days. But that negative test on, day 1 or day 7 or whatever, it's not going to tell you whether or not you're going to develop that the virus later on. So we have to keep asking that question for 14 days. So that's our quarantine.
That's awesome. We educators get alliteration. So isolation, illness. Got it.
And this is Joe McLaughlin. One of the questions that I see being repeated in a few different ways in the question box is around how do you define close contact? So close contact is, by CDC definition, 15 minutes or more within 6 feet of an infected person. Now, that we kind of say that, and I think most states agree, and probably CDC would agree as well, that it's a cumulative thing. So if you spend 5 minutes with somebody who's infected, and then an hour goes by, and then you spend another 5 minutes, and then an hour goes by, and another 5 minutes, those 5 minutes accumulate, and then you would be at that 15-minute mark for close contact. Now, there are some circumstances where it's really difficult to determine whether or not a teacher, for example, may have had close contact with all of the students in their second or third grade class. And let's say the teacher is infected and just doesn't remember how many of those students he or she had close contact with during their infectious. In that circumstance, we typically err on the side of caution and would look at quarantining, all of the students in the classroom, depending on the situation. Of course, we always have to take a look at each situation uniquely. I don't know, Liz, if there's anything you would add to that?
Only that this is something that we work with you on, that this is one of the things that public health, I think, can really partner with schools and make sure that, we have guidelines, and then there's all sorts of edge cases, and there's all sorts of, but this, and this happened, and none of these are in the guidelines. And I think that's where we can really help.
All right, good to know. We're in this together.
I have a question just to comment on, because I know, and this is for just the understanding of around Alaska, because I know you, Dr. Olson, Dr. Zink, and Dr. Margotha, everybody, Dr. Coleman, you work with everyone around the state and just some other school districts that have started, and in every school classroom, it is almost simply for physical space reasons to really time and time again for over time to maintain the 6 feet. So how are schools with mitigation, the additives? I think you had mentioned that once, Dr. Zink, that it's an additive. It's not just one thing that is going to get us where we need to go. It's a multiple of things, and that's why it's so hard to answer. How are other school districts really, their teachers and their parents and their kids operating, knowing that, there's going to be times that we are not exactly 6 feet. And in real life, that happens too. We're in grocery stores, we're passing people, we're, going into the post office and stuff. The signs are on the floors, but it's not always our own ability to control or influence other things. So can you talk about that a little bit? Just because I think that happens to be the biggest fear. If we say 6 feet, then it must be terrible. And I know it's a risk kind of level, but is there anything that you've learned from other school districts?
Yeah, I think, we can both definitely chime in here. And, Dr. Olson really gets the fun work of going through each of these cases and going through all these plans and seeing the creativity across the state and the ways that people are thinking about all this together, from busing to sports to schools, and some ideas. I think that you make a great point in the fact, again, it's not just kind of black or white. I think a lot about schools in terms of healthcare. So really when healthcare was open and we were trying to figure out what COVID meant, there was just a lot of fear, and understandably so. With nurses and doctors, and we still see heights of transmission in the healthcare facilities between nurses and techs and house cleaners who are helping to care for facilities. But we've also learned a lot in that time and what ways we can mitigate it. And so you talk to our healthcare colleagues and they'll joke that every hour there was a different mitigation plan, and every day there was a different mitigation plan, and you just couldn't keep up. By the end of the day there were 3 new proposals and plans that were out there, and it felt like total chaos. But most of the healthcare facilities have settled into something that is reasonable and that you can really mitigate risk, and you learn to use your tools. And so you learn to use your PPE, ventilation, distance, doing things you never used to do before. In the emergency department, I never used to FaceTime a patient in triage to see them. I just go see them. But now I FaceTime them, and to minimize the number of contacts of what that looks like. And so we've learned to practice medicine really differently. And I think that kind of anxiety level has settled down. Doesn't mean it's risk-free. It doesn't mean it's perfect, and it doesn't mean that there isn't added risk when we're there together, but there's this risk benefit that we're all trying to figure out in providing healthcare, not having delayed healthcare, and in this case with schools, having kids be learning in person, because we know that there are risks of not having kids in person, particularly younger kids. And so I think so many schools are going through the same process that healthcare did initially, where there's a new protocol and plan every 15 minutes, and it feels overwhelming and chaotic. But that is part of the learning process, and that's where the two-way communication is incredibly important. And I think it's going to start to settle out, and that's what we've seen in other districts. The Matthews School District's been in place for about a month now. It's not perfect. There's still cases. There's still a lot of learning going on, but the learning's kind of settling down a bit. And you're kind of learning, this is how we communicate when there's a positive. This is how we communicate when this happens. And we're learning a lot of that together. And so I guess that would be the biggest thing that I've seen is we're just learning better ways to separate, and then also being creative about our space, doing things outside, being able to, use gyms and gymnasiums, use other spaces, using, the building network, using trailers. I know, some classrooms have just moved to the trailers outside to minimize the risk, changing what that risk looks like depending on kind of the level. And every school is a little bit different about that. Dr. Olson, what other great tidbits do you have from the other schools and experiences?
Yeah, I think most of the ones I talked about already, but I definitely think that being creative is central, and many different school districts have really come up with different ways of approaching this, and making sure that anytime we do have to be within 6 feet of each other, that's brief interaction, and then also making sure that all of the other mitigation measures are in place.
Okay. So looking at the other questions that I have here, I realize that we haven't invited our ASD panel.
Speaker is off. Would you like to say anything, Dr. Coleman?
Yeah, I can address. I kind of skimmed through all the questions. I was going to mention testing to kind of clarify some of the testing questions. So there was some questions in here about if it requires a doctor's order, and Technically, a COVID test does. A lot of the sites are operating under what's called a standing order. So, for example, if you were to pull up to one of the drive-through sites in Anchorage, technically a doctor is ordering that test. You just might not know who it is. So I encourage you to look at our state testing map. It's on the state dashboard, and it has testing sites for all over the state. If you click on them, they have some information. But if the question is, would it require an order or not, and it's not answered on that map, I would reach out to the testing sites within your community. The other thing, I think there's a lot of confusion in social media and in the mass media about COVID testing. There was a couple questions about like testing everybody every morning or like testing is related to travel. As it pertains to like what Dr. McLaughlin was talking about, where, we don't really know we're infected. It's a really tough disease too. I mean, Dr. Zink talked a lot about this and Dr. Olson, where, clinically it's hard to say. There's a lot of viruses that have the same symptoms. And also a negative test, really, it doesn't tell me, all it really tells me at this point is I'm not positive yet, because there's a certain amount of virus that has to be present in your nose for that to flag a positive. So when we talk about testing, there's really three types. There's molecular testing, and that's the type of test like a PCR that looks for the actual viral material, the genetic material of the virus. Those are the most sensitive and the most specific, so they require the least amount of virus to detect a positive. And when you test positive on those, it's pretty close to 100%. Really, the only time we see false positives with those are in contamination and things like that. Then the newest tests that have gotten a lot of traction in the news and on the media are the antigen tests. Antigen tests do detect the virus, but they look for surface proteins. They do have a higher false negativity rate. They require more of the virus to detect a positive, and they also do have some false positive rates. We've been using antigen tests for years for things like flu and RSV, but right now, as it stands, there isn't a whole lot of great data in terms of using them in a clinical setting for surveillance, and for screening, for looking at people without symptom and then deciding if they have the disease. The last thing I'll kind of mention around this is the rapid tests. A lot of people are talking about the rapid tests. The rapid molecular tests are great, but they're really low volume. For example, if we had all 760 people on this call who wanted to take a rapid test, it would probably take 11 days for the last person to get the results. The first person might get theirs in 30 minutes, but the last person is going to have to wait about 11 days. So that's there. And in terms of sending to our state labs and the high capacity labs, about a 3 to 4 day turnaround is about as fast as we're ever going to get. It takes, roughly a day at the lab in best case scenarios. I will say that we're in a great situation too in terms of access to testing. We're the #1 most tested state, and in most communities now people can go in and get a COVID test if they need one. I don't know if anyone else has anything to add for testing. I tried to cover all of it in 2 minutes or less.
Well done. Well done. All right. Anyone else want to chime in on testing? All right. Well, looking at the time now, it's 5:20, and we do have a couple of things to take care of as we wrap up. But first, I wanted to ask our school board president, Elisa Vicalis, if she has any words that she would like to share.
Hi, thank you for having me as part of the panel today. And I know that there are several other board members online as well that are getting the opportunity to listen to the questions. We just want to say thank you to everybody participating, whether they were a panelist, a speaker, a teacher, a staff member, principal, everybody that participated. I'm pretty sure you got more attendance than our average board meeting. So just wanted to say thank you, and we look forward to continuing the discussion as we move forward. Thank you.
Thank you. I'd like to echo that. Thank you to all of our panelists for their time today and helping our staff and community to better understand our district's plans to safely reenter our schools for in-person learning. Special thanks to School Board President Elisa Vicalis and our partners, AEA President Corey Ace, APA President Patrick Freeman, and Totem President Sandy Thompson-Wallace for serving as panelists today. They may feel like they got off kind of easy today. Who knows? Maybe next week. We'll see. And a shout out to the support staff who had helped make today's town hall happen. Lisa Miller in communications, Carrie Gray and Raquel Schroeder with the Echo Project, Joe Barron and his fabulous team in project management, Nancy Epstein, our closed caption support from Cap Division, and the incomparable Janet Hayes. Remember, this is the first of 3 ASD town hall meetings on the ASD reentry plan. The next meeting will be next Tuesday, September 29th from 3:30 to 5:30. And the final town hall will be Wednesday, September 30th, also from 3:30 to 5:30. Sorry. My other production support just popped in to give me a note just to let everybody know that all of the questions that are in the Q&A will be answered. So we will stay tuned. We will find ways to make sure and share those with you. Anyway, back to the ASD reentry town halls. All of those will be, or the 2 additional ones next week will be by Zoom webinar, and more meeting information may be found on the Anchorage School District website at www.asdk12.org. At this time, I'd like to invite Carrie Gray to share her screen and talk.
Yeah, can I just share one thing before
Sure.
Carrie sends? She's giving more information on, some of these echoes, and I'm kind of an echo addict now by the medical profession that I've gone to several different ones, and it really, the lightning round you have to see because it is really good. But this team here is phenomenal, and I've learned so much from why hand sanitizers to washing, what about the vaccine, and I come back and to the office and I share with my team what I learned and try to test them to see if they knew anything about what I learned that day. And so I would highly encourage our staff to tune in or see if you can find time for those. They are really phenomenal. And a special thank you. I know it's a long day because you start first thing in the morning with these types of things. You go all day. You were on one at noon today, and now you're staying, a little bit into your dinner time. So I want to personally thank you. I believe in what public schools do for children as well as public health, and partnering with you is going to bring goodness to our city and to our young people. So I wanted to personally thank you for that. And now back to you.
All right. So Carrie, for those who are interested in Dr. Zing's Echo Project Zoom sessions, Carrie Gray is going to share with us a little bit about an upcoming one.
So thank you, Tim. Thank you, Dr. Bishop, and also thank you, Dr. Zink, and all your staff for attending today. We just want to be clear. I'm wondering, Tim, if you can share your screen if possible. So the Alaska Education Network project is starting up their Echo sessions the first week of October. And we just wanted to let you know of one special one that we're having on October 28th. Dr. Zink is gratefully going to be one of our presenters in one of our Echo sessions. So that's October 28th, 3:45 to 5 p.m. You can register at our website, echoeducationak.com. For ASD staff, you can also find Project Echo Alaska Education Network on Support Central under the instruction title. And as Dr. Zink was mentioning, there is lots of Echo projects happening. UAA's Center of Human Development, those are the Echo projects that she is heavily and her team are involved in. And you can find out about those. The quickest way you probably can do that is Google UAA Echo, and you'll find that page will come up and you'll find all their COVID echoes. So no matter if you attend the Alaska Education Network or the ones through the Center of Human Development, Echo sessions are great. They're very informative, and we invite all of you to attend the ones that you think would be of value to you. So please find out about our Alaska Education Network Echo sessions on our website, and you can also join our mailing list. So very easy to do. If you go to our website on the right-hand side, it says join today, and you'll get all the information 2 times a month. But if you're ever in doubt, please join our mailing list and check out our website. And of course, attend October 28th with Dr. Zink. So thank you very much.
Thank you, Carrie. And I can say I've participated in a number of those Project Echo sessions, and they are fabulous. So, all right. Well, here we are at the end of our time together today.
Our guests. Thank you, thank you, thank you.
Indeed. Thank you, everybody, for being here. Finally, actually, I'd like to take this opportunity on behalf of the Anchorage School District to thank you for being in this town hall meeting and for helping us prepare for elementary and middle school students and staff returning to in-person learning, hopefully in the second quarter of the school year. Until next time, thank you and have a pleasant evening.